All right, and I just started it.
All right, great. First of all, thank you guys for all being here to listen to me speak today. My name is Kelsey Miles. I'm a physical therapist in Charlotte. And tonight I'm going to be talking to you about evidence-based modalities and the intensive therapy model. Okay, so like I was speaking with Karen before, shameless plug for my company. I am the owner and sole practitioner at Move Pediatric Therapy. I started my business almost a full year ago. My 1-year anniversary will be in November. And if you follow me on Instagram, you will be seeing this lovely video again to celebrate 1 year. These are all the kiddos that I've seen that I've had the ability to record. My primary caseload is children from 0 to 5 years old. And I primarily treat children with moderate to severe brain injuries. I also work with your typical developmental delay, people with near fatal drowning incidents, things like that. I also see patients that are teens, but I don't go too much above that age group, not for a lack of wanting to, just that's who sees me. So that is where I'm at. I started in home care. So a lot of the pictures and videos you'll see, I'm treating children in their homes. But I recently opened a clinic in the Noda neighborhood just outside of Uptown. And I started seeing kids there right around July 4th. So it's been awesome. I see kids throughout the Charlotte area, and I also see kids throughout the country. My furthest kiddo has come from Belgium, the country, and then I've also seen a good amount of people from the Pacific Northwest, and primarily my kiddos come from this Southeast region, Virginia, Georgia, Florida, North and South Carolina. So that's just a little bit about me. So the evidence-based modalities we're going to speak about today are, first of all, intensive physical therapy, which I do provide, vibration plates, Theratogs, the TheraSuit, and electrical stimulation. So we're going to speak about intensive therapy first. This is one of my kiddos who has done numerous intensives with me, and he was one of the first kiddos to do an intensive. So definitely has a special place in my heart. So if you're looking at the literature, intensive therapy is often referred to as IMOT, which just stands for intensive method of therapy or intensive model of therapy. It's defined as participating in therapy 2 to 4 hours per day for 5 days a week, up to 3 weeks. There are some clinics that offer 4 to 6 weeks intensives. I only offer up to 3 weeks, just mostly for scheduling purposes. And a lot of clinics offer multidisciplinary intensives where you'd see OT for an hour, PT for an hour, and speech for an hour, or some combination of those. I only offer single discipline just because I'm the only practitioner at my office. So why the intensive therapy model is so important and why it's so effective. The muscle atrophy for a child that's immobile or a child that has a limited use of their muscles acts very quickly. We start to lose actin and myosin, which are the contractile units of those muscles, on day 1 to 3 of immobility. And I'm not speaking about just full immobility. This could be limited or non-use of a hemiparetic limb or something like that. We start to lose muscle fiber diameter in 1 to 2 weeks. And then the biggest thing, which I'll be speaking a lot about, is the conversion of muscle fibers. And this starts to occur on week 2 to 3, again, of disuse or immobility. So I educate parents a lot on this conversion of muscle fibers. It's well researched in the literature. It's been researched on athletes, on people that have just become injured, adults, children. There's a lot of research out there. So again, this occurs in that 2 to 3 week time period, which is coincidentally the timing of most intensives. The conversion of muscle fibers is speaking about the conversion in the negative sense of red muscle fibers to white muscle fibers. Our red muscle fibers are those that are used for isometric holding. There are postural muscles. They're the ones that keep our head upright all day. They keep our trunk upright all day. Now, a lot of the kiddos that we see, specifically the ones that I see, have very difficult time using these red muscle fibers because they rely on oxygen to perform. When you have immobility of a muscle, those red muscle fibers within that muscle start converting to white muscle fibers. And unfortunately, those white muscle fibers, which are really great at quick movements, lasting anywhere from 3 to 5 seconds, cannot perform the task the same way as the red muscle fiber. So if we have a child who is immobile and those muscle fibers are primarily white, they're only going to be able to contract their muscle and activate their limbs for that 3 to 5 second period, potentially slightly longer with compensatory movements. So we need to make sure that our kiddos are moving. The recommendation is at least 1 hour of aerobic activity per day within these 2 to 3 weeks. Again, 2 hours or more is better. And that's where that intensive therapy model comes in. It's really important to kind of build upon those skills and build upon those aerobic activities to really get those muscle fibers, prevent them from converting, and then also get fibers that have converted to go in the positive direction of becoming those red muscle fibers again. Because without those red muscle fibers, like I said, we're not able to hold our head up, we're not able to keep our trunk up. And without those postural supports, we can't functionally move our limbs. So main thing, get kids moving and keep them moving. For my more involved kiddos, I recommend a lot of movement in the pool, a lot of movement in a tub if parents have a large garden tub, use of adaptive bike. It doesn't have to be independent movement. Active assisted movement has been shown to be just as beneficial for getting that conversion or preventing that conversion to white muscle fibers or converting to the red fibers, which we want. We also need to talk about supercompensation, which ties directly into that intensive therapy model. So supercompensation is when we have, it refers to the post-training period, which the trained function has a higher performance capacity than it did prior to that training period. So this is all coming from a book that's based on physiology from Bamba. It's called The Methodology of Training and Human Kinetics. And they looked at supercompensation and found that the period of 24 hours to 48 hours after a high level aerobic activity of 1 hour or more allowed for those skills that you were working on to kind of build on top of each other. So with intensive therapy, it's a great model because you're typically seeing a child at the same time every day. You're getting approximately 24 hours between each of those sessions, and you're able to get that supercompensation, which allows for structural, functional, and chemical changes to the muscles and to the body in general. So again, like I said, a lot of the research indicates that intensive therapy programs should be no less than 3 weeks long, approximately 3 hours per day. That's not always feasible for families. I do offer intensives that are 1 to 2 weeks long as well. With finances, with parents taking off of work to travel to see me, with other kids in the picture, it's just not always feasible. And that's where our role as physical therapists or OTs or whatever you're doing to help these children, you want to make sure you're giving them a really solid foundation and a really great exercise program in between those intensives. Or if you're only able to provide services 1 or 2 times a week due to insurance barriers, you just want to make sure to educate the parents on why this is so important, how we want to prevent that conversion of the muscle fibers to improve that functionality of their child. Okay, so looking at the research, there's a ton of research out there on intensive models. I tried to pull the most recent articles that are looking at children that we would typically see as PTs or OTs or speech therapists. So Sorsdahl et al. Looked at a group of children that did therapy for 2 to 2.5 hours a day, 3 days a week over 6 weeks. So you would consider this an intensive, but kind of a mini intensive, given that they're only doing 3 days a week. And he found that at least 2 periods of consecutive training were able to improve significant gross motor function that was not expected from typical development. He found that there was a small drop in gross motor skills between those intensive periods, but if children participated in 4 or more intensives, then there was no drop in skills in between. Again, I know that this is not all real life. Most people can't do 4 intensives in a row that are each 6 weeks long, just presenting the evidence that is out there for therapy. In the study by Ru and Suh, that was a very recent study this year, they looked at 23 children that were ages 1 to 5. All of them had a diagnosis of cerebral palsy. They had groups that were high frequency in exercise and low frequency, and they found a significant difference in the high frequency group, making better improvements on the gross motor function measure. They also found what's been shown in the literature over and over again, that children younger than 36 months made greater gains than those older than 36 months. And children that were independent ambulators or moving towards independent ambulation made more improvements than non-ambulators. Both groups, pre-ambulators and ambulators, made great changes, and children over the age of 3 months also made changes, but they weren't as significant. And then the study by Christie et al., this was a great study because it looked at a lot of different outcome measures. They looked at 17 kids who worked for 4 hours a day, 5 days a week for 3 weeks. So that's a pretty standard intensive schedule. They tested the gross motor function measure. They looked at the COPM, which is the Canadian Occupational Performance Measure. And they looked at the PODCI, which is the Parent Reported Outcome Measure. And this looked at everything from how the parents perceive the interventions to functional ability to independence and self-care, leisure, socialization. So this was a really good study. And this study was awesome because it found that those changes with intensive therapy remained at 3 months without additional intervention. Okay, so that's intensive therapy. Again, if anyone has any questions, feel free to add them in the chat. I'll get to them probably at the end, and we can kind of scroll back through the slides if needed. So the next thing we're going to be speaking about is vibration plate. There is a ton of literature out there about vibration plates and how they can help. The WBV stands for whole body vibration, and that's the type of vibration that I'm going to be speaking about. That just means that we're using the vibration plate to access multiple muscles throughout the body. We're not using a massage gun or a vibrating tool to access just the hand or just the foot or something like that. So this is whole body vibration, and that's all the evidence that I'm presenting today. There's numerous models out there. The Hypervibe and the Galileo are going to be your gold standard. A lot of larger organizations have these. They will set you back quite a few dollars. The Galileo runs about $5,000 to $10,000, and the Hypervibe runs about $1,300 to $4,300. Both are just considered gold standard based on the amount of motors they have. They have really nice oscillatory patterns, meaning kind of like a wave-like formation, which helps to prevent accommodation of children that are using the device. And whole body vibration pairs super, super well with handling, which is great news for therapists out there, because that's what we do. We handle kids, we help them move through space. You don't want to just stick the child on the vibration plate and let them stand there or sit there. You want to be doing an active movement. And all of the research that I looked at, out of all of them, they found really great results, except for the studies where there was a low duration of use or where children were just statically standing and holding on to a support beam. So we want to make sure, just in the video that just played, that you are moving kids through transitions, tall kneel, half kneel, sit to stands, getting them moving, and single leg stance, things like that.
Kelsey, we had a question in here. Can you place the vibration plate in the chat? And you can do it afterwards if you have a link.
I'm sorry, could you repeat that?
Sorry, somebody had asked if you can place the vibration plate in the chat. Do you have a link for the plate? Or?
Yes, there's actually a link coming up at the end of the presentation.
Okay.
That you can either jot down or take a picture of, or I'm happy to post a link in the chat at the end.
Okay.
No problem.
Perfect. And then somebody else, and maybe you'll get to this, asked the cost of the intensive and do you take Medicaid? But maybe, I don't know if you'll do that later.
I was not going to address that. I do not take any insurance. Insurance, unfortunately, does not really offer compensation for intensives, even though there's a plethora of research out there stating that this could be very beneficial. This is very beneficial for kids. Unfortunately, insurance is way behind the times. So I do accept grants and fundraising money and things like that, but I do not accept insurance currently.
Thank you.
Thank you. So again, whole body vibration, there's a ton of benefits listed here. It's really great at giving proprioceptive input. I can speak firsthand as I sit on this device probably a total of 60 to 70 minutes per day. Most of my children I put on there for a duration of 8 to 10 minutes, sometimes a little bit less, but that's typically about the time I spend on there with them. And there aren't many precautions. This can be used in a wide variety of patients. I'm only going to speak about the pediatric caseload, but this is used in patients that are looking to lose weight, patients post-stroke, patients that have difficulties with their bone mineral density, things like that. So main precautions are recent fracture. That's obviously a very serious precaution. I would state that it's really a contraindication. The osteoporosis, that is not a huge, that's not a contraindication. It is a precaution. If someone had that diagnosis, I would check with their doctor because, again, as I stated, there are a lot of research studies on increasing bone mineral density with this, with a vibration plate. High fall risk, I don't really consider a precaution. I know they have to list that on a lot of the research studies, but 100% of my kids are a high fall risk. I'm right there with them, holding on to them. So that to me is not really a precaution. And then the only reason that uncontrollable seizures is on the list is that, again, that chance of a high fall risk. It is safe to put children with seizures on the vibration plate. I have 90% of my kids have seizure or epileptic activity, and the research indicates that there is no increase in activity because of this vibration. Okay, so looking directly at the research, the frequency, amplitude, and duration of use of the vibration plate varied in all of the studies, but looking at those studies, most can agree that the best benefits come from a 15 to 20 hertz frequency, an amplitude of 2 to 3 millimeters, which is the amount that the plate is moving. A lot of plates, you cannot change the amplitude, just as an FYI, and a duration of 5 to 10 minutes for 3 days a week. And again, as I stated before, in studies that did not show efficacy of whole body vibration, all of the patients were passive. Again, the one that spoke to me the most was kids were standing on a vibration plate for 1 minute, 3 times a week, and they were holding on to a support beam. So not even their full body weight needed to be on that vibration plate. Looking at some very specific research, the research by Tekin and Kavlock showed significant improved gross motor function in 22 patients with hemiplegia. These children were all under the age of 10. They saw a significant increase in balance, gait, and decreased spasticity, and these results lasted even 3 months post-study. So that was a great study. They found that kids were walking further, almost 75 feet more on the 6-minute walk test. Their gait velocity was improved, and their GM-FCS scores actually improved a statistically significant amount with use of vibration plate. The study by Adekina et al. That looked at the 2 different frequencies, And they found there was no difference between the group that did 20 hertz versus 25 hertz, which is fine. 25 hertz, if you've ever been on a vibration plate, is very, very high. I would not recommend that for most kids. It is hard for me to even tolerate that. Sorry, I need to turn that sound off. That's just one of my friends doing a sit to stand on the vibration plate. So the study by Adekina et al. Found, again, in addition to gait speed in the 6-minute walk test, in addition to walking further, they found that bone mineral density changed and improved, and they found that sit to stand velocity improved. And then the study by Jung et al. Looked at 30 children. They were on the vibration plate kind of a long time, for 30 minutes, 3 days a week. And they did a study with a control group, a study with kids with whole body vibration just standing on the plate, and then whole body vibration while doing activity on the plate. And that whole body vibration group with the therapy on the plate made significant gains on multiple tests, including the sit to stand, the timed up and go, 6-minute walk test, the pediatric balance scale, the GM-FM, and the timed up and down stairs. So best summary for that, use the vibration plate. It will help your kids out tremendously. One thing I did forget to mention was there are some really nice low cost models. Two of my favorites are the Life Pro and the Bluefin Fitness. Both range from about $100 to $300. So again, they're not inexpensive, but they're way more affordable than the Hypervibe and the Galileo. And those are something that I often recommend to my parents if they reach out and ask me about something that could help their child. In this picture with this child, that is the Life Pro. And I believe that model is around $300, but there are less expensive models certainly out there. All right, next we're going to talk about Theratogs. Theratogs are a really great modality that I recently started using. I was just certified in using them a few months ago, and I pretty much use them on everyone now because I have seen so many gains with this modality. And there's a ton of research out there on Theratogs as well. The Theratog has a foam liner and it has a nylon kind of top. There's a front and a back to the vest portion, as you can see on this child. And then there's a short portion, which they're all kind of overlapping with Velcro. There's also leg cuffs and arm cuffs you can use that are not on this child. And then the white straps are a heavier duty elastic that can influence certain muscles and certain postures. So I kind of went over this. They say they're lightweight and breathable. I haven't had any children complain of being hot in them, but there have been reports in the literature about children not wanting to wear them when it's 100 degrees out, which I do not blame them for. You are supposed to wear them underneath your clothes because I see multiple children and I'm using these for multiple kids. I have them wear them outside just for sanitary reasons. But traditionally they are worn under the clothes. They help correcting posture alignment so that you can really learn to use your extremity as well for functional tasks. And they provide really great proprioceptive input to help with increased afferent signaling for better motor control and motor learning. So I love this picture of this child. This picture was taken, the first picture was taken no more than 5 minutes before the second picture. On the left, we see limited weight bearing through her feet, not a lot of engagement with her lower extremities to help her maintain her balance, a significant posterior pelvic tilt leading to a rounded back and a forward head. And in that second picture, again, I did not do any handling, any stretching, anything. I just plopped her, honestly, that's on the vibration plate right there on her seating system, and I emphasized use of the elastic bands to give her a really nice neutral pelvis to help give her a great base of support. She was independently able to pull her legs in and get her feet flat on the floor, which is very challenging for her independently to do without the Theratogs. And you can see her back is nice and straight now, and her head is almost fully over her shoulders. The other awesome thing about this picture is that she was able to engage with a toy while using the Theratogs, which she is not able to do while she's sitting independently without the Theratogs, because she needs to typically hold on to her body in order to keep herself upright. So if that picture doesn't sell you, I don't know what does. So looking at the research, El Shami and El Kafi had a randomized control trial, and they looked at a lot of spinal geometry. And this graph on the right-hand side is from their study. They looked at 40 children with spastic diplegia, ages 6 to 9 years old, and they did a 3-month treatment protocol where the children in the experimental group wore these Theratogs for 12 hours a day, 3 days a week, and had PT, versus a control that only had PT. And all of the exercises were the same. So this is a really good study because everyone did the exact same exercises, but just one group had the Theratogs. And as you can see in this chart, the experimental group, which is pictured in blue, they had almost a doubled in improvements as compared to their control group counterparts. So their trunk balance was significantly better. Their pelvic tilt was improved. They had less lateral deviation of their pelvis and their trunk and less rotation. In the study by Elhart, this looked at children with dyskinetic cerebral palsy, which I thought was pretty unique because most of the studies were done on children with hemiplegia or diplegia. In kids with dyskinetic CP, there were 30 kids in this study, ranges from 8 to 12 years old, and they found a huge improvement in gait and posture with use of Theratogs. They found at the hip, there was a ton more hip extension from mid to terminal stance. There was increased push off during that terminal stance phase, so propelling themselves through space got a lot easier. And they had better initial swing phase in clearing their limb to be able to advance their foot forward. The only con that this study found was self-care, and that was mostly relating to personal hygiene after toileting. So that is something to think about because, again, they're wearing this device right next to their skin. Few other studies, Chang et al. Found again that there was a ton of improvement in gait. They looked at foot motion as the child was swinging their foot through during stepping. Traditionally, a lot of children have difficulty maintaining that movement in a sagittal plane. This study found that that sagittal plane or forward plane movement really improved, and that the path of pressure from initial contact to loading response, or when their foot first hits the ground, was much better. So they were getting nice initial contact with their heel. They were getting some weight moving from laterally to anterior medially to get that push off at the end of stance phase. And then multiple studies, again, with the Theratog showed that there was improvement in the knee joint alignment, improvement in the ability of the hip muscles to contract, which we really need for stance phase and swing phase, but more so stance phase in order to make sure that the child doesn't fall to the floor when lifting up their opposite leg. And there was a reduction in scissoring with the Theratogs. Okay, now we're going to move on to the TheraSuit. This is one of the TheraSuits. This is the yellow. There's also an alternative called the NeuroSuit, which is very, very similar, just different companies. You can see that it is made of a canvas-like material. It's a lot thicker than the Theratogs, but very similar premise. There's a lot of, on this picture, there's a lot of little yellow hooks that you attach bungees to facilitate different movement patterns or help activate different muscles. There's also knee cuffs, which you don't see on this child. And there's also arm cuffs and foot attachments that you can use to really emphasize assistance on the ankle. So we kind of talked about this. It's used to treat adults. It's used to treat children. The person who made this, her name is Isabella Colsini. She developed it in the early 2000s because she had a daughter that was born prematurely and does have CP. And she kind of looked everywhere to find something that would help her child. And she came up with this. I took the course from her 2 years ago, and she is a wonderful presenter and a wonderful source of knowledge. So if you have the opportunity or the desire to learn about TheraSuit, she is your woman. She is awesome. There's not too many contraindications or precautions. The main ones are that if you have a child who has delayed mobility skills, you don't want to put the suit on them until they're about 2 to 2.5 due to delayed formation of the acetabulum. You want to make sure that you're not affecting their growth plates in any adverse way. And traditionally, our kids with limited mobility don't have as much practice with weight bearing. So we want to make sure that we're giving them that time for that acetabulum to develop a little bit better. So the main goals of the suit are really to help with postural control, which we spoke about before. Help those postural muscles stay stable, maintain those isometric holds in that position to allow for the limbs to move to complete functional tasks. You want to facilitate proper movement synergies and reduce compensatory muscles from trying to take over. You want to load specific joints to give really good proprioceptive feedback. And during the course, you get to wear an adult size suit. And I can tell you that it is, if you like input, it's awesome. If you hate a lot of input, you would hate wearing this suit. It gives you a ton of compressive forces through your joints, and you can really feel pretty much everywhere that you're moving through space, which is super helpful for our kiddos who sometimes have difficulty figuring out where their body is and how they're moving it. It also is great, just like the Theratogs, it provides dynamic correction through transitions, through gait. It's not something that's blocking movement, it's facilitating movement. So it's really, really helpful for that. And then again, the postural muscles versus the movement muscles. We want to make sure that the postural muscles are doing their job, the movement muscles are doing their job. And a lot of our children with CP, you'll see them kind of posturing with their arms up like this when they're ambulating. And that's a direct result of them having weak postural muscles and trying to use other muscles, in that instance, their biceps, to stabilize their trunk. Again, the movement muscles don't have that capacity just physiologically. And so that's where you see that abnormal posturing. And the TheraSuit's goal, as well as some of these other orthoses, is to really help provide stability to that postural system so that we see less of those compensations. So this is a little cutie with the TheraSuit on. You can see kind of the back of that. And she does have the knee cuffs on and the ankle attachments or the shoe attachments. So looking at the research, the first research by Norian et al. Looked at 12 kids with spastic diplegia, and the mean age of these children was 10 years old. They found a significant increase in balance after the TheraSuit intervention. And this decreased hip and knee range of motion was actually a positive effect of the study. They found that there was less hyperextension, less genu recurvatum at the knee, and decreased hip flexion or decreased crouch gait. They did find one negative was that walking speed decreased with use of the TheraSuit, which is kind of understandable because it is a little bit of a heavier device for a child to wear, especially a small child. Study by Chun et al. Was a larger study. It looked at 56 kids, and this group had a control group and the TheraSuit group. Both groups made improvements, but only the TheraSuit group made statistically significant improvements on the pediatric balance scale and the gross motor function measure. So that was a really great study. And then Martin's did 2 studies, and both of those looked at wearing the TheraSuit during gait. They found that the TheraSuit had immediate impacts on lower limb positioning during gait, and they found that the most changes were seen at the ankle. So in this study, the child was wearing the knee cuffs and the foot modification. with the bungees up and down the leg. They found that there was increased hip extension during stance phase, improved knee extension when the foot was getting ready to contact the floor during gait, and also decreased plantar flexion or improved ability to clear their foot at initial contact. So that was a really awesome study as well. Okay, the next thing we're going to be talking about is electrical stimulation. In this picture right here, you can see the wires hanging down from this child. We are stimulating her glutes in this photo. A lot of times, if you guys follow me on Instagram or have seen any of my photos or photos that I'm sharing today, you'll see wires and kind of a device lurking to the side. That's what we're doing. We're doing e-stim. So
Kelsey, before you keep going, there's two things in the chat about the TheraSuits.
Okay.
Megan Rispoli asked, she said she used to use the Theratogs a lot years ago, but in recent years had trouble getting them ordered, no insurance coverage, orthotists no longer providing them. Do you have patients ordered privately or directly from the company? And have there been any updates in the ordering process with coverage?
Yes, that is an awesome question. I have actually had a ton of success recently, like in the last month or so. And I just, not before that, because I wasn't ordering them before that. But I've been working with an orthotist, and as long as you are coating the Theratogs and also getting the Dragonfly TLSO portion, which is a harder device. It wasn't shown in any of my pictures, but it has kind of bands that are more rigid that wrap around the rib cage and the shoulders. As long as you're coating the Theratogs with that device and they're both used together, you can get coverage from most insurances. So I've had kids with Medicaid get them covered, and I believe Blue Cross Blue Shield. Don't hold me to that one. I know definitely Medicaid has covered this for 2 of my kiddos. And again,
Megan, if you had any other questions, feel free to stick it in the chat.
Hi, Megan.
And then from Kaylee Sylvester, do you have any differences in Theratogs versus TheraSuits as far as adapting to children of different sizes? I found that the canvas material, I found that the canvas material and sizing of the TheraSuits makes it a bit hard to adapt to kids in between sizes, but thought maybe the Theratogs would be more stretch.
Can you repeat I missed the very first part of the question.
That's when my kids are making noise. Do you find any difference between Theratogs versus TheraSuits as far as adapting to children of different sizes?
Okay. Yes. So I do agree with you. I think that the Theratogs are a little bit easier to size up or down. They are supposed to fit very snugly, the Theratogs, and it's sometimes a little bit difficult to get the TheraSuit as tight on the body, depending on the child's anatomy. So I have used both for the same child. I do feel that Theratogs is a little bit easier to move in for the child. It's a little bit easier for the child to activate rotation and kind of move through that transverse plane. But I find that the TheraSuit does a better job at really facilitating and stabilizing those postural muscles. So I think there's use for both of them out there for sure.
There's one last question. Would you recommend the Theratog for a kiddo who has significant external rotation of one hip and therefore is having a challenging time with walking?
Yes, I think that would be awesome. You said Theratog, was that correct?
Theratog, yep.
Theratog. Yeah. Yes, I have actually used just the short portion and a thigh cuff on children with external or internal rotation pathologies. It has been very, very beneficial. There are some children, and I'll kind of get a little bit to internal and external rotation briefly at the end of the discussion, and some different things that I use to address that. But yes, if a child has awesome trunk control and we're only focusing on one limb or 2 limbs or something that's more distal, I will use either the short portion and the thigh cuff, and then use one of those white elastic straps to facilitate the movement that I want. So yeah, I think it's a great idea to try.
And that is all we've got in there. Oh, wait, one more. Are Theratogs suitable for children with hip subluxation?
Yes, they are safe for children with hip subluxation. Just to be cautious, I would get a verbal okay or a note from their orthopedist, but there is not as much pull with the Theratogs as compared to the TheraSuit, where the TheraSuit, it's really important to make sure that you're not causing more subluxation. I didn't mention it, but the TheraSuit is really safe for kids with 30% subluxation or less. With the Theratogs, there is not as much pull, so it is safe. But again, I would just err on the side of caution and make sure that the orthopedist was okay with that.
One last one, and then you can move on.
Okay, no problem.
So as far as Theratogs, are you ordering those for each patient versus a TheraSuit where you buy a set to use in the clinic?
Great question. So I have a set of Theratogs for my office. And again, that's why you saw all of them on the outside of children's clothing. I ordered a few different sizes to kind of go between that 0 to 5-year-old clientele that I typically deal with. And as my kids get older, or as I start seeing older kids, I'll probably just order bigger sizes as necessary. For if a child is really doing well with them, then I'll have a conversation with the parent saying, hey, I think this is something, the research points to wearing this for 6 to 8 to 12 hours per day. This is the research behind it. This is why it's effective. And I think we should consider this. Now, if the parent's not into it, I'm definitely not going to force them to use them. If they're not willing to put them on at home, it's not going to help the child at all. So I just say, hey, this is the research behind this. This is what I think personally and professionally would benefit your child. And we kind of go from there. If they're into it, great, we order it. If not, then we just keep using it in therapy and move on from there.
All right, thank you.
Okay, thank you so much, Karen. All right, so electrical stimulation. I know that we have a few people on this chat that use electrical stimulation a lot. So if you have anything to add, feel free. I'm specifically going to be speaking about TASIS, which is a type of neuromuscular electrical stimulation, and it stands for task-specific electrical stimulation. This was developed by Judy Carmick. She is still practicing. If you want to take her class, it's awesome. You can still learn from her. I would bet that she's probably not going to be teaching for too much longer. She's fairly old, but she is smart as a whip. And you could just, any picture of her, you'll see with like 20 units strapped to her and her just facilitating every muscle in the body. So it's really fun to watch her work. Traditional NMES looks at activating the antagonist of the spastic muscle. So for instance, if I have a spastic bicep and my arm is stuck in this position, traditionally, NMES, you would stick the electrodes on the tricep to try and activate extension out of that spastic pattern. With TASIS, you actually want to emphasize placing the electrodes on that spastic muscle, on that tight spastic muscle. And the reason for that is that muscles that are spastic are not strong. That's a common misconception. There are tons of research articles out there on spasticity, and that spastic muscles are actually very weak. They're just getting incorrect signaling from the brain, incorrect sensory input, and therefore they are staying tight. So with this picture, I just want to show you, I love this picture, this just for reference, because you can only see half of her body. This is a child facing away from us. She's holding on to a bed. She's not able to stand independently yet, but we're getting close. This before picture, she has the electrodes on, but she does not have any stimulation. I haven't turned the machine on. You can notice that her feet are in a significant supination pattern. We've got excess weight bearing through the lateral aspect of her feet and no weight shift posteriorly. There's no weight through her heels. She has very poor awareness that her heels are even there and that she can shift backwards. Where I have the electrodes are on her, the active electrode is on her medial gastrocs. You can see in this on her right leg that the electrode is a little bit distal to the other electrode, and that's just because of the anatomy of the medial gastrocs, where the muscle belly is lower than that lateral gastrocs. When I turned the machine on with the parameters, again, I'm on the spastic muscle, that tight gastroc or calf muscle. As soon as I turn it on, we got this beautiful posterior weight shift. We got weight, really nice weight through both heels. Again, this is not perfect. I did not stretch her. I did not touch her. I did not facilitate anything. This is just her body's ability to now be able to strengthen, use that new and strengthened muscle of her gastroc. So again, her left foot's looking really nice in this photo. The right foot, we still have some varus positioning of her calcaneus, but again, it's much better compared to the before picture. So just wanted to show you that. I like to show that to people. And looking at the precautions, there's not too many precautions. Some of the precautions do include not putting the electrodes over the chest, over the heart, nothing on the neck, not over pacemaker or cancer or open wounds. The e-stim is okay to use with children with seizures. There is no clinically significant increase in risk of seizures with electrical stimulation. So again, most of my kids have seizures and they have all done excellent with this modality. So looking at the research, El-Shami and El-Kafi looked at gait parameters and postural stability in 30 patients. They were 8 to 12 years old with hemiplegic CP. All of these patients were ambulatory with or without an assistive device. And this study actually looked at comparing children using TASIS and PT, and the other group used Theratogs and PT. So it's kind of interesting. They did find that both studies or both modalities had an impact, but in using the e-stim, there was a bigger impact on that gait as compared to just the Theratogs. And then Shortland et al. Looked at a study with children using TASIS and strength training, and they compared that to other modalities, including serial casting and lengthening of muscles via stretching. And they found that there were significant improvements with use of TASIS as compared to those other modalities. Two other research studies, Salazar found significant improvements in sitting and standing balance. This is a meta-analysis, meaning they looked at multiple research studies. And so there were 174 children within this meta-analysis. So again, they found sitting and standing to improve, but they found improvements in walking, but not that were statistically significant. So they were unable to count that towards the TASIS data. In Chi-Hung study, it was again another meta-analysis, and this included 294 patients. They compared TASIS to constraint-induced movement therapy, to robot-assisted therapy, and to dynamic bracing. And this was a study done on upper extremities, and they found huge gains in functional scores and decreased spasticity and increased strength in upper extremities. And it was great because these results lasted for 3 months after the study, which is when they tested again. This next slide, I do have 2 older studies. I said before I was trying to add more recent studies, but these are studies done by Judy Carmick, who invented TASIS, and they are pretty exciting in terms of changing the way that people look at children with cerebral palsy and changing the way that the expectations we have for them. So in her 1993 study, she found a significant improvement in gait symmetry and an improvement in locomotor efficiency in older children. Prior to this study, and still today, a lot of people will tell you that once your child is around 5 years old, they're not, and they have a neuromuscular condition, they're not really going to make changes in gait. They're not really going to make changes in their functional mobility skills. And Judy proved this wrong in this study. in her study in 2013, she found that children actually improved on the GMFCS level. Prior to this, there were people, well, pretty much everyone was saying once you're 2 and you receive a level on the GMFCS, you pretty much don't change levels. You stay in that level forever, no matter what kind of therapy you do, etc. She found that 44% of her kids actually gained a level, which is huge. That could be going from walking with an assistive device to walking independently without a device, or being totally reliant on someone for mobility, to being able to use an assistive device with some modified independence. And in her study here, no one regressed, which is huge, because this chart on the right is what older studies had presented, in that the straight line, or the lines, the solid lines, indicate that if you're level 1 or level 2, you kind of make gains and then you make slow improvements until your teenage years. Whereas older studies, again, level 3, 4, and 5, make some gains until about 5 years old, and then actually have a decline in function. In Judy's study, which this chart is from, she is plotting dots on one specific child who started therapy with her around 2.5, 3 years old, and made significant gains up until the end of the study, which was when the child was 9 years old. And this child actually changed levels, which is a huge deal for someone with CP. So that was really exciting. I like to share that with parents. It's nice to give parents some hope that's actually backed by science and research, I should say. All right, this is a child, this is just a demonstration. This child has diplegic CP. He has significant knee flexion contractures. He never achieves heel strike. You can see he's heavily reliant on his arms for ambulation. He's fully independent with these canes, but has a lot of difficulty with that functional gait pattern. On this next video, these videos were taken 2 minutes apart. I just slapped on some electrodes. You can see they don't look great on the left leg. They should look more like the right leg, but I put them on his spastic hamstring muscles, the muscle that is tight and that is preventing his knee from fully extending. And we got significant improvements in his gait immediately. Now, his gait is not perfect, but looking at the change with no facilitation and no stretching and no therapy in between these videos, you can see where we're getting almost flat foot contact. We're getting his hip to translate over his knee, a nice anterior weight shift, and he's able to move with a lot better base of support and keeping his feet almost flat. Again, I'm not saying this is like a miracle and it's happening perfectly, but there's a huge improvement in gait with this child. And these are just still pictures that I wanted to show you. These are not same day pictures. These were taken a few months apart. This was when I was working in a child's home. This is the hand of a teenager with hemiplegia, and she is 15 in these pictures. Her primary concern when I started with her was that no one wanted to give her a high five because her fingers were hyperextending, like you can see in this bottom right hand picture. This was her before. With TASIS, again, we worked on this for months. This was not before, like right away, but in that first picture, you can see she has no active wrist extension, no metacarpal phalangeal extension, significant hyperextension of her interphalangeal joints, and compensatory flexion of her distal IP joints. After TASIS, we have really nice wrist extension, really nice metacarpal phalangeal extension, and really graded finger flexion. And again, this was automatic after this few months of therapy. She no longer hyperextended her fingers unless she was in like a very stressed out situation. This top right, she had no finger approximation prior to therapy, and by the the end of those few months, she was able to approximate her thumb and first finger and her thumb and second finger. And we were still working on that ring finger and pinky finger, but she got 1 and 2. And the bottom one, which she was most excited about, was she was now able to high five her friends with a more what she deemed normal looking hand. And so she felt a lot less self-conscious of going up to her friends for a high five. So again, you can make changes as a older kiddo. Okay, we're almost finished. Thank you guys for hanging in there with me.
I've got 2 things in the chat about eSTEM.
Okay, go for it.
All right. So how are you able, this is from Avery Hurst, how are you able to perform TASIS on a child who is nonverbal and are unable to tell you when the sensation is felt? Do you do very low level? Are there certain levels that work best for certain muscle groups? Like, for example, lower level for forearm versus higher level for quads.
Yeah, so unfortunately, it's all very individualized. How I do it, I mean, I would say I only actually see currently 2 children who are verbal. So 95% of my kids I'm doing this on are nonverbal. I make sure to start it at a very, very low level. One, I always test it on myself prior and kind of see what level I'm at. Now, my neuromuscular system is intact, so it's not always going to be the same, but I just make sure kind of where I'm feeling the sensation. I make sure that when I'm putting it on a child for the first time, that they are in a calm state when I put it on. So I can make sure if they're screaming prior to me putting it on and then they're screaming afterwards, I have no idea if they're just screaming because they were screaming before or if something's hurting them. I look a lot at a kid's eyes and mouth, and if their eyes are getting wide or you see any sort of nonverbal cue, then I know that, okay, maybe we went a little too high. I would much rather err on the side of caution and keep that intensity low and just maybe even let them get a sensory input instead of a actual muscular contraction to start with until they can kind of gain a better understanding of what sensation they're feeling and why. Did that answer the whole question?
I think so. And I think it also answered the second one that asked about what parameters you start with. And then Haley says, my son doesn't speak much yet, but he does great with TASIS, and Kelsey is a pro at application.
Thank you, Haley. You're the best, and your kiddo is amazing. All right, guys, last few slides. We will do this so quickly. This is just kind of a random slide. These are not the next two, whoops, sorry. The next slides are not evidence-based interventions, but they go along with evidence-based interventions because they are all helping to facilitate that postural alignment, again, which we need for distal mobility. So straps and supports that I often use, and this is what I was talking about when I stated before about internal, external rotation of the hip. This might answer your question a little bit better, give you some different ideas. I use 1,000 straps. Anyone who's seen me knows that I have kids strapped up to the max. Again, all to provide that postural support so that their muscles can work in the best alignment possible. So I use Chattanooga bands, which you'll see on the next slide. Super wraps, that's on this picture of this child. These are these white straps. They're made of Fabrifoam. They're very elastic. I use them on legs, arms, abdominals. In this case, I'm using them to provide proprioceptive input and a little bit of external rotation and increased gluteal contraction for this child. So I'm wrapping them going from medial to laterally and fastening them on her buttocks, again, to get her glutes a little bit more fired. A waist trimmer, that's not a medical device. It's like a $5 neoprene thick strap that's marketed towards people who want to lose weight. It's great because it doesn't provide full support, but it provides a little bit, again, of proprioceptive input. I just stick it on their waist. The towel roll you can see in this second picture is a really great low-cost option that I give to families who might not be interested in something more medical looking, like a head collar or a head master or a Hensinger collar. And this is just a kitchen towel that's rolled up, and I have a hairband on the one end of it. Always making sure that opening is out so you can get your fingers in between the throat and the towel, just for safety. And of course, just educating parents that you don't want to walk away when this is on. But again, this child in this picture has intermittent head support. She can hold her head up, but it's very inconsistent. Most of the time her head is down looking towards the floor. So this is great, not only for those postural muscles, but also just for socialization and engagement. And then I use immobilizers every single day, all day. I love immobilizers. So if you don't use them, I'm not going to share today, but I'm happy to share with you at another time how I use those. These are the super wraps or the Chattanooga bands, excuse me, I was speaking about, the blue bands. And this device up here is actually the Tasis, the Continuum model with her little band. So we got her all strapped up. We got TheraBands and all sorts of things. Again, postural alignment, I already hit on this 1,000 times. We want to make sure that we're taking care of those muscle spindles. So going back to physiology, the muscle spindles that are the mechanoreceptors inside the muscle, they're the ones responsible for indicating to us when a stretch occurs. If a child doesn't have activation of certain muscles, say they don't have head control, their muscle spindles in their neck are going to end up being very overstretched because their head may be over here, and then it's over here, and then it's down, and then it's up. So we need, whenever I'm working with a child, I always think I need to make sure these muscle spindles are knowing when they're supposed to activate. Typically, when we move our head, I move my head this way, my muscle spindles on this side say, hey, I stretched a little bit, I should move back to a neutral position. With kids that are moving their heads all around, just as an example, again, we want to make sure that those muscle spindles can tighten up and really feel that stretch so that they can respond appropriately. And if they're always constantly moving, that's never going to happen. Just a little side note.
Yeah.
Oh, sorry. I didn't realize she was walking there. Okay, I'm going to go on. Okay, summary. We made it to the M. This is the headmaster collar I was speaking about. It's a really great alternative for kids that have a trach because it's open in the front, allows for clear airway. It's great for kids with a vent as well. You can string the vent through that. And this child has no head control, and she's able to keep her head up really nicely so that we can work a little more distally on other muscles. So main summary, again, get your kids moving and find a way to keep them moving. It's so important to prevent that conversion of those red muscle fibers to those white muscle fibers so that our kids can be functional and move. We want to present the facts to the parents that more is better. Certainly, I never want to talk about this in a way that is like, hey, you have to do more or your kid is going to not do well. We just want to present the facts that, hey, it's really important to get your kid moving, to help them move, and that way their muscles can get stronger, and that way they can do more things functionally independently. In summary, there's tons of evidence on intensive therapy, vibration plates, and Theratogs. There's really good evidence, but just not a ton on the actual Tasis. There's a lot of evidence on NMES, but Tasis in general, there's good evidence, but not a lot. And I would say there's fair plus evidence on the TheraSuit. That might not be a super fair statement because I did take out all of the evidence that was based on the TheraSuit and the spider cage or the universal exercise unit. I kind of separated those out. But that is something important to know. And then always, always, always facilitate optimal alignment for best outcomes using these devices, using strapping systems, using immobilizers, whatever you have, please use it. Help these kiddos. Again, references, please email me. I have my email on the next slide. I'll let you guys take a look at that. If you want a full list of resources or references, most of the slides, if you look back, they have the author's name and kind of what the study is talking about. And then these are the main websites for a lot of the things that I spoke about, including the Hypervibe, the Galileo, Theratogs, Tasis, and TheraSuit. If you have the ability to take any of these classes, I would recommend it. They are awesome. Okay, we made it to the end. Thank you guys for hanging in with me. if you have questions or want to chat, my email is kelsey@movepediatricpt.com. You can check out my website. You can also send me a note on there at movepediatricpt.com. And then if I do share some therapy tips and tricks, and also a ton of videos of the cutest kids around on my Instagram, which is move.pediatric.therapy. If you guys have any questions, I'd be happy to answer them now, but thank you so much for being here and for listening.
Thank you, Kelsey.
Thank you. There's a couple more here in the chat.
Okay.
Krisha asked where to get trained for Theratogs and Therasuits, and what sizes do you recommend for 0 to 5 age?
Okay, great question. Theratogs, there is a virtual component. You can go to that website and sign up. There's a virtual component, and then there is a lab-based component. You take the virtual component on your own, and then that puts you on a list for them to reach out to you about a in-person component, which is lab-based. And they try and kind of group people together by region of the country. Therasuit, there are Isabella Colsini is the one who does all of that training. And I took the course in Florida. I believe she's in Michigan. Don't quote me on that. A lot of the training that I see that she does in Florida, because she said she wants to get out of the winter, the Michigan winter. So I would just look at that website. That's her website, that Therasuit. And you can, her email is on that website. She's really great at her daughter is actually her administrative assistant, and we'll get back to you right away. And the sizes for most kids, like 2 to 5, I would say the preschool size works really well. And then if they're younger than 2, there's an infant size, but there is sizing